So for the paediatric anaesthetists and obstetric anaesthetists who've been sitting here patiently for 6.5 hours, just waiting for these last half an hour, your time has come. Mark Thomas from Great Ormond Street is going to talk about small people.
Thanks, Tim. Thank you, and thanks to the NAP6 group for all the work we've done over the last 4 years. It's been fantastic to be involved with it. So here's the summary, if you like, the take-homes here. In common with other NAPs, we've called children those under 16 years and banded them in age groups 0 to 5 and 5 to 16, so essentially preschool and school age. And the 2-day snapshot survey yielded 2,053 paediatric cases. Multiply that up by the magic number we heard about earlier, and you get to just over 400,000 paediatric cases done annually. So that's our denominator, about 400,000 paediatric cases. There were 11 cases, paediatric cases, of grade 3 to 4 anaphylaxis. There were no grade 5s, so no children died. This gives us an instance of 2.73 per 100K, with the confidence interval shown there, versus the adult figure of 9.36. So we're around a quarter of the instance of adult severe anaphylaxis. There was 1 in the under 5 group, and then the remaining 10 were in the school age group. That's the 5 to 16-year-olds. What the anaesthetists thought at the time, this is the first question you get asked, isn't it, when you see, if you had a case, if you were unlikely to have had a case, what was it to? And this was their answer. Atracurium in 3 cases, the index anaesthetist felt, and then single cases of each of those listed there. So notably, there was a ticaplanin that they felt was responsible, but on later discussion and testing was ruled out as a potential. But lidocaine, sux, piptazobactam, ticaplanin, aprotenin, cefuroxime, ibuprofen, and cryoprecipitate. When we got to the panel discussion, we were fairly sure, having had quite lengthy discussions between us and then together, that there were 7 definite high certainty cases. 2 were atracurium, and 1 each of those following. So aprotenin, sux, ibuprofen, and cefuroxime. Vecuronium, we were uncertain of the degree with which we could label it, but okay. So how many times were those drugs administered? This is the key question, of course, because if it's a commonly administered drug, you expect to see more reactions to it. And for atracurium, that was certainly the case. 14% of paediatric cases get atracurium at some point. So it's the biggest, as in adults, the biggest or the most popular choice for a non-depolarizer. And there were 3 cases reported, as I mentioned. Ibuprofen, 17% of paediatric anaesthetics the kids get ibuprofen around the time of their surgery or procedure. And we haven't, because of the low numbers, we haven't ascribed risks to each of these agents because we recognise that they're quite low numbers, and it would probably be unfair, although you could certainly say that atracurium is the commonest. So why is it that children are about a quarter as likely to suffer a severe anaphylactic reaction at the time of their anaesthetic? Well, there are a couple of reasons we might explain this away. One is that neuromuscular blockers are used about half as frequently in children as they are in adults. So 24%, just under 25% of paediatric cases get blocked compared to 47% of adult cases. And when a relaxant is chosen, in paediatrics, 57% of the time, it's atracurium. And then rocuronium is the next most popular choice, and succinylmethonium the most popular choice after that. So that's 5.2% of paediatric cases, but 21% of the relaxants used in children, 2.5% of paediatric cases, and 10% of the relaxants used in children. Another interesting observation, at least to me it was interesting, was that 14% of children get nothing other than sevoflurane for their anaesthetic. So this are scans or EUAs and that kind of thing, things that probably most adults would be able to tolerate awake. Kids have to have an anaesthetic for, but they only get sevoflurane. This is a very low allergen stimulating anaesthetic, obviously, so that's kind of a group that you wouldn't expect to have an anaphylaxis, if you like. And then antibiotics, a similar story to non-depolarizers, out of the big two here. Again, about half as frequently administered to children as they are to adults. So 26.4% of kids get an antibiotic versus 57% of adults. And notably, ticaplanin, which was one of the big four, only 0.9% of kids get that versus 7% of the adult population. So the other notable missing allergen from that table is latex, and as we've seen in previous talks, and this is probably down to the fact that it's around less, and many hospitals declare themselves latex-free environments, and we're more aware of the risk of latex. And as I say, ticaplanin is less frequently used in children, but also it may be that children, because they haven't been on the planet as long, are less likely to be labelled as penicillin allergic, and therefore, whether that's a correct label or not, as we've discussed earlier, are therefore less likely to receive ticaplanin as the first-line alternative to penicillin. Oops, I may have gone forward here. So what about the first feature? Well, bronchospasm was actually the commonest first feature in children, in contrast to the cardiovascular presentation in adults. And in 7 of the cases, it was the first, either bronchospasm or high airway pressures was the first presenting feature. And all occurred quite early on, so within 5 minutes of the administration of the suspect agent. Hypotension occurred in 2 and tends to be slightly later, so more than 5 minutes after the administration of the suspect agent, with tachycardia, rash, and a decrease in CO2 occurring, as you see there. Moving on through the case, hypotension becomes a bit more common and develops in kids who presented with high airway pressures or bronchospasm, and 9 out of the 11 cases develops hypertension at some point during their anaesthetic. I should say that we used the same definition of hypotension across all the age bands. So clearly, a child of 1 is a blood pressure of 50 or 60 is not necessarily hypotension. So that's perhaps something for discussion. Okay, the good news is that consultant was involved, at least not necessarily initially, although in very vast majority initially, but in all the cases by the time it was declared an anaphylaxis. And bronchospasm, when it occurred in 7 of the cases, within 6, resuscitation started within 5 minutes of the administration. So very quickly onto it. And if hypotension or tachycardia or rash was the presenting feature, slightly slower onto it. It was slower to present, and therefore slightly slower to twig to what was going on. Obviously, there's a larger differential, you could argue, with hypotension and tachycardia than there is with bronchospasm. There was one slow to appear rash, which took 15 minutes to twig to. Almost all the kids got adrenaline, as you would hope and expect, and 10 out of the 11 cases got that, and the delayed one was the one that didn't get it. And the highest number of doses was 9, with 2.5 being the median number of doses. Again, almost all of them received steroids, hydrocortisone in most cases, 8 and 1 dex, and then the same number, and in fact the same patients, received the chlorphenamine. And 8 had mast cell tryptase, at least 1. 7 were locally reported, but as we heard earlier, the MIHRA reporting could be improved upon. Only 2 were issued with a bracelet. So here's a very paediatric slide. For those of you who don't do a lot of peds, we've presented the fluids given as mils per kilo. So if you think of a 75-kilo adult, 20 mils per kilo represents 1.5 litres in the first hour. So here you've got a median of 20 mils per kilo just about in the first hour, and then dropping to just under 10 in the subsequent 2-hour windows. 10 received crystalloid, 1 got a gelatin, which again we could discuss, and 1 received no IV fluids. That was the delayed presentation. What about the guidelines? Well, almost half anaesthetists used the AAEGBI guideline, or at least they said they did, and in one case did they reach for the RCUK guideline. 7 had access to a sticky back plastic laminate in the operating theatre, and just surprisingly to my mind, for a group of anaesthetists, no one reached for their pocket to bring out their iPhone to look up any algorithms that they may have on the front page there. The review panel, the great and good in the college here, deemed that the management was good in 7 cases and had good and poor elements in 4. Okay, so there were no arrests as judged by a heart rate of less than 60. There were no deaths. 1 patient and parent reported anxiety about future anaesthetics. I'm sure maybe everyone had them, but only 1 reported. And 1 report of a child having some withdrawn behaviour after the event. It's not my area of expertise, but investigation in children is going to be a challenge always because, not least because of their compliance with skin prick testing and intradermal testing, but nevertheless, there are some room for improvement here, I think. The Allergy Clinic identified 7 triggers with high confidence, and a panel added to that by 1. There was deviation from the rather strictly applied guidelines in 7 out of those 8. As we heard earlier, there may only have been minor deviation, but nevertheless, we deemed it deviation. And this included failure to test for possible triggers or safe alternatives, or to establish a baseline MCT, which can be done, obviously, post-hoc. And as a result, 5 out of 8 were judged to still be at risk or given poor advice. So none of them were deemed very good, but we did have quite strict criteria by which we were judging. So in summary, it's pretty rare, 2.7 per 100,000. There were no paediatric deaths, which was a great relief. It was generally well managed, very early recognition, and very well managed when it was recognized by senior people. Atracurium is the single biggest trigger agent in this series, and the clinic and follow-up management could be improved. Thank you.
As you can probably tell, it's been an absolute pleasure to work with all these people, with the clinical immunologists, with the allergists, and even with the anaesthetists. And also those from the allergy charities and, of course, the patient groups. It's been an absolute pleasure.